Hello everybody, so we will discuss renal concepts focusing on the different disease process that might be involved and what is our role in regards to that. So as you all know, this is the male urinary system. Okay, so we have our kidneys, we have our ureters, our bladder, and our urethra, and also for female. Okay. And again, our kidneys, each kidney has millions of nephrons, and nephron is the functional unit of the kidney. And as you all know, our urinary system is very important in excretion, filtration, absorption of toxins. And as you can see here, we really need our 20% of cardiac output for our kidneys to perfuse properly. And of course, if perfusion is enough because of the 20% cardiac output, then your patient will have a normal urine output, which you all learned from fundamentals of nursing. It should be about 30 ml per hour. But since you are already at complex adult health, learning these concepts again, is that you need to understand that you have to calculate it by using 0.5 ml per kilogram per hour. So for example, if your patients weigh 50 kilograms, then what you need to do is you multiply the weight by 0.5, and whatever the answer is, that would be the ml per hour for that patient. So in short, let's say if we multiply this 0.5 by 50 kilograms, let's say, then it means that when you multiply this 2, the answer would be 25. So it means for a patient that weighs 50 kilograms at 25 ml per hour is a normal urine output for that client. Okay. And another thing that you need to look at is the GFR. Okay. And with GFR, it decreases as we age. So as you can see in here, normally our GFR is about 125 ml per minute. But for example, if your patient is 70-year-old elderly client, normally at that age, our GFR dropped by 50%. So if the normal is 125 ml per minute, then by the time we hit 70, this 125 will drop to about 60 to 65 ml per minute. And remember, this is unexpected finding for a client who is 70 years old. Now let's talk about acute kidney injury. So let's talk about the different underlying causes of AKI. So we have pre-renal causes. Pre means before the kidneys. So we're talking about any disease processes that happen in cardiac or in the heart, lungs, brain. So for example, heart failure. Okay, while intrarenal means inside the kidneys. So anything that happens inside the kidneys like nephrotic syndrome, glomerulonephritis, acute tubular necrosis. So that happens inside the kidneys. While with post-renal, we're talking about after the kidneys. So anything that is like that can affect the ureter, the bladder, the urethra, that is post-renal cause of acute kidney injury. Now, when it comes to signs and symptoms, I want you to remember the 3 different phases. So we have here the oliguric, and this means that the urine output of your patient is about equal to less than 400 ml over 24 hours. While diuretic phase means that your patient started to urinate a lot. And recovery phase, this means the lab values started to become normal and the body starting to recover, especially the urinary system. So if your patient did not reach this part in here, your patient will develop chronic kidney disease, which is also known as end-stage renal failure. Okay, that's why it's very important for all of us nurses to understand the acute kidney injury and what are the signs and symptoms of them. Now, we already talked about the pre-renal causes earlier. Remember the word before. So we're talking about the heart, the lungs, the brain, or any disease processes that can affect those. Intrarenal causes, as I said earlier, inside. So anything that affect the nephrons, glomerulus, or other parts that you can find inside the kidney or kidneys. Post-renal, we're talking about after the kidney, so we're talking about the ureter, the bladder, the urethra. Now, this is just a table showing you the different underlying causes. So again, the easiest way to remember them is by knowing what pre means, what intra means, and what post means in here, so that you really don't have to memorize them, but try to understand that, hey, it can happen before the kidneys, or hey, it happens inside the kidneys, or hey, it happens after the kidneys. All right, so let's take a look at this table. I know this seems a lot to look at, but I want you to use this table as a reference when it comes to the different clinical manifestations, because you have to understand it. So what we're going to do is we're going to start looking at the oliguric phase first. And as I said earlier, with oliguric, your patient is urinating equal or less than 400 ml over 24 hours. So this is what's going to happen. Since your patient is not urinating as much, your main concern is the fluid volume overload. And what's going to happen if your patient is accumulating a lot of fluids is your patient will have, let's jump into cardiac, will have high blood pressure. The heart rate will be high, as trying to compensate with so much fluids. However, because of that, because of too high blood pressure and too high heart rate, the cardiac output is low. So when you check the stroke volume of this patient, it might be high because the volume is high because of so much fluid, but the heart rate is high, which is not good. But it doesn't mean the cardiac output will climb up. It will be low because cardiac output is the amount of oxygenated blood that is delivered in the systemic circulation, which is not enough. Okay, now, since your patient is accumulating so much fluids, then it can also affect the oxygenation. So when you check the patient's respiratory rate, it's high, trying to compensate with so much fluid, your patient will be breathing too fast. And when you check their O2 saturation, it's low. So what's going to happen is your patient's ABG will be respiratory alkalosis, wherein the pH is high and the CO2 is low because your patient is, not oxygenating properly. Now, when you look at their mentation, since the oxygenation is very poor, then your patient will have altered level of consciousness. So when you say altered, it means that your patient might be confused, combative, and there are risk for seizures, because if the body is accumulating so much fluids, then your patient will have fluid and electrolyte imbalances. Okay? Now, when you check their urine output, remember, we're talking about oliguric. So this means urine output is low, but the concentration is high. So when you check the osmolality, the specific gravity of this patient's urine, they're high. Okay? Now let's move on to diuretic. What's the difference? Now with diuretic, your patient's starting to urinate a lot. So now your main concern is the fluid volume deficit. And when you look at the level of consciousness, it's the same, it's altered, but when it comes to volume, remember, it's low. So when you check their blood pressure, it is low, but the heart rate still high as part of compensation. And remember, if any of the two, whether it's the volume and the heart rate, is abnormal, then the cardiac output is low. Okay, now as part of compensation, since there's no enough volume, the respiratory rate is still high, or it can be normal, and the O2 sat might be low or it might be normal, and ABG may also be normal at this point. But when you check their urine output, since they're urinating a lot, then urine output is high, but the concentration is very low. Okay? And remember, when you say diuretic phase, they are urinating about 150 ml per hour or more. Okay? And of course, recovery, this is what we want to see, that neurologically and other system-wise, they are improving. So this is just to show you that if the urine is about this color, like amber, then it's very concentrated. So when you check urine osmolality, it will be high, and urine specific gravity will be high. And it's the opposite when the urine is not concentrated. When your patient is urinating a lot, it will drop the concentration. Now, let's move on. So this is to show you what's gonna happen to the diagnostic test. What will you see? Okay. Now, let's start with oliguric. Remember, oliguric, your patient is retaining so much fluids. They are not urinating as much. So when you check their sodium, it is diluted because of so much fluids. That's why there is for seizures. Their potassium, since they're accumulating, they can have high potassium. But when it comes to magnesium, calcium, and phosphorus, it might vary, okay, per patient. Now, the bond and creatinine this time, since the kidneys are not functioning really well, there's a possibility that you might see an elevation in their bond, because that means that we really have to investigate what metabolic condition causes this, and creatinine might be a little bit in the high side. Okay, now since your patient is accumulating a lot of fluids, when you check their chest x-ray result, there might be a pulmonary infiltrate or pleural effusion because of the fluid volume overload. Okay, now when echocardiogram is done, remember, it depends per patient, but if you see that the ejection fraction is in the low side, that's not a good sign. That means that the patient's heart function is dropping. Okay, but as I said, it varies per patient. Now let's move on to diuretic phase. Diuretic, this means that the urine output is high. So when you check the sodium, since your patient is urinating too much, then it might be in the low side, because it means that your patient has been urinating it or getting it out of the system. So, when you check the other electrolytes, it might be the same. It might be low also, okay? But when you check the bond, it might be high, but you might also see some improvement wherein the trend of the bond is dropping. So let's say the bond, when you check it, it is about 25 or 30, and then let's say today it was 27, and let's say tomorrow it becomes 25. So that means it's getting better. Okay, it's still high, but it's improving. So that's what I mean about looking at the trend. And same thing with creatinine. Okay, now with chest x-ray and echocardiogram, again, it might vary per patient. Now recovery phase, so you can see here that everything is improving. So with this, again, is you will see normal lab chest x-ray and echocardiogram results. All right, so what are we gonna do then? Remember, your management for acute kidney injury differ depending on what's going on with your patient. So if your patient is an oliguric phase, remember the main focus here is the fluid volume overload, the high potassium, and possible seizures. So your management will focus on that. Okay, So as you can see on the first one is neuro. So I do this system wise. So neuro, again, you want your patient to be safe as much as possible. And since they are at risk to have seizure, you want to put them on seizure precaution. You want to make sure you have something, a medication that will help stop seizure, which is lorazepam IV push. Okay. Now, with cardiac, remember, they are accumulating a lot of fluids and they are at risk to have hyperkalemia. So you want to give medications that can excrete so much fluids, like diuretics. Okay, you can use the loop diuretics. You can use also some antihypertensive agent in here. However, remember that when you use ACE inhibitors, you have to watch your patient because using it can also predispose your patient to develop hyperkalemia. So be cautious. That's why it's highlighted. And again, with oxygen, again, for the respiratory function, so you want to give them oxygen as needed, put them on the highest position that you can, and monitor the respiratory status. Okay? When it comes to urine output, you have to monitor the output, and you also need to monitor the intake of your patient. Okay? Now, when you get to diuretic phase, remember our main concern here is the fluid volume deficit. Now, this time, your main concern is replacing the electrolytes that were lost due to too much diuresis. So in here, you want to replace those electrolytes. But as you can see, number one, we're doing the same thing that we are providing patient safety in here. And you want to make sure you have the medication on standby. And remember, as you replace the fluids and electrolytes, make sure you monitor it, okay, closely. And you check their vital signs, you perform head-to-toe assessment, or you can do focus assessment depending on, what's going on with your patient, and check intake and output. And as your patient recovers, you just do health teaching. Now, let's go back to oliguric phase. So in here is, with hyperkalemia management, you've learned this from fluids and electrolytes imbalances and management. We have to give medications to them. If they're stable enough, you can give something rectally. If they're unstable, then you wanna give something fast acting medication like something IV push. You give it to your patient. And with diuretic phase, as I said, replace the fluids and electrolytes that were lost. Now, let's move on to chronic kidney disease, or also known as end-stage renal failure. So earlier, I said that acute kidney injury has a recovery phase, and our goal is for our patient to recover. But if they did not recover, then they will develop this disease process. So there are many underlying causes in here why your patient has chronic kidney disease. Okay, so again, when we're dealing with patients who have this, is we want to make sure that our goal is to treat them, to manage them, for them not to have chronic kidney disease or end-stage renal disease. So there are different stages of CKD or end-stage renal disease, and there are 5 stages in here. So again, they look at the GFR, or the glomerular filtration rate. So the lower it is, the higher the stage is. And you will notice that, like for example, with stage 3B, the GFR is 30 to 44. Stage 4, it drops to 15 to 29, and less than 15, stage 5. And technically, dialysis starts at either stage 3 or stage 4, depending on what's going on with your patient. Now, when it comes to CKD or end-stage renal disease, again, I did it by system so that it's easier to, get organized and understand this. So remember, when a patient has chronic kidney disease, this means that the filtration, the absorption, the excretion is not happening. Okay, so what's going to happen? All of those toxins that are not needed by the body are accumulating. So because of that accumulation, when you check the bun and creatinine of this patient, they are elevated. They are way too elevated. And your patient, because of that accumulation of toxins, they are very confused. Okay, they're very confused. There are times they are lethargic, they're combative. So you want to make sure that you provide safety precautions. And you want to make sure you monitor not only the level of consciousness, but also the bun and creatinine so that you can see if your patient is improving or not. Okay, and for cardiac, remember, they have the tendency to accumulate a lot of fluids. So again, your main concern here is high blood pressure, high potassium, arrhythmias. So your management will focus on, focus on treating those. So if your patient has high blood pressure, then you want to give them antihypertensive medication. You want to make sure that they go on dialysis, religiously, so that they are not accumulating so much fluids. And when it comes to potassium, then again, dialysis will help, but also we can also give them medications like the ones that are listed here. Okay. Another thing that is another concern here is the dyslipidemia. So patients who have chronic kidney disease, again, um, their triglycerides, their lipid panel are not in a good shape for patients who have chronic kidney disease. So we have to monitor their LDL, HDL. And as you can see here, the VLDL is high, and that's not good. So here we give statins, to decrease that dyslipidemia, and also to watch our patient for possible development of heart disease. Okay. Now for pulmonary, remember, they're accumulating a lot of fluids, and their ABG result will be metabolic acidosis, because again, going back to ABG, and the norm is that the kidneys are the one that regulates bicarb, which is the buffer. And because of chronic kidney disease, is the body becomes acidotic, so the pH will be low, and the bicarb will also drop in here. So your patient will have metabolic acidosis. Again, what helps here is we give them oxygen as needed. We can administer sodium bicarb, IV push, and also another thing, dialysis, because dialysis also helps to normalize the bicarb level in the body. Now for GI, I know this seems a lot, okay? So GI, the problem with patients who have chronic kidney disease is that they can develop diabetic gastroparesis. So they're at risk to develop malnutrition, and especially if they are diagnosed with diabetes. That's a big problem, okay? So they're on dialysis, they have insulin, and we have to monitor their glucose level. And we need to make sure that they are compliant. And the thing is, even though they don't have diabetes, the problem is before the dialysis starts, their insulin tends to go up in the blood. So that's why we tend to look at some evidence-based practices that patients who have chronic kidney disease, it seems that they have diabetes type 2 because of this. Okay, and we treat them with insulin and with other medications to decrease the blood glucose level. And again, when it comes to diet, it varies again. If your patient is not on dialysis, we need to restrict them for them not to eat anything with protein. Okay, but if they're on dialysis, they can have normal protein diet. And if they are on peritoneal dialysis, they can have high protein diet, because with peritoneal dialysis, they lose a lot of protein by using this type of dialysis treatment. Okay, now let's move on to genitourinary. So I've been talking about fluid volume overload, and for sure fluid and electrolyte imbalances is, again, dialysis will help them. So that's why it's very important for them to be, to go on dialysis religiously. And another thing that can be a problem is hypermagnesemia. It only occurs when your patient takes medication that contain magnesium. So you want to make sure you check their whether it's over the counter or prescribed medications. Okay. While with musculoskeletal system is, again, they are, at risk to develop mineral and bone disorder because of that imbalances in their electrolytes. And their calcium and phosphorus are not in a good shape in here, and that can also affect the parathyroid gland. So what's gonna happen is you watch their phosphorus. If it's high, then we give them phosphate binders. Again, these are the phosphate binders that we commonly use: calcium acetate, sevelamer, hydrochloride. And if they have hyperparathyroidism secondary to chronic kidney disease, want to give them calcium reducer like sinacalcet. Okay, and again, if calcium is imbalanced, then their bone will be affected too. So that's why your patient need to have check bone density. Need to check the bone density, CAT scan, MRI. If osteoporosis is present, we can administer alendronate as ordered, and we want to make sure they are really compliant with dialysis. Now, with hematology, since the kidneys are failing and going back, normally kidneys are important or has an important role in the production of erythropoietin. So since the kidneys are failing, then of course the erythropoietin will be low, and this condition can lead to anemia. So what's gonna happen is we administer epogen, or also known as epoetin alpha, and the goal is about 12 grams per deciliter. So if hemoglobin is low, increase the dose. If hemoglobin is high, decrease the dose. So I just put it here to make sure that as a nurse, you have to check their hemoglobin level. And if you think that, hey, this is too much, this is too low, you have to call the healthcare provider. Okay? Now, we've been talking about dialysis and how important it is for our patient to be compliant, because dialysis filters, reabsorbs, and help excretes the toxins from the body. So these are the different terminology that you might see in your NCLEX, like ultrafiltration, that means removal of fluid; blood flow rate, that's the speed on how fast the blood will be filtered. Okay, dialyzer, it's an artificial filter containing fine fiber. I'm gonna show you what it looks like. Dialysate, it's a solution, and dialysate bag, it's a bag with solution, and the solution contains electrolytes, dextrose. Okay, now in here you will see different types of dialysis, and don't worry, I'll show you the images of those terms that I showed you earlier. But let's differentiate the different types of dialysis. I remember doing dialysis before, and I've been doing hemodialysis for my patient 3 times a week. Peritoneal dialysis will be pretty much every day, and CRRT, we do this also in ICU. Okay, so let's start with hemodialysis. So hemodialysis, this one is a blood filtering procedure. Okay, so In here, we want the blood pressure stable. So when you say blood pressure stable, it means that the mean arterial pressure is 60 or higher. That means that there's a good perfusion in the body. The patient can tolerate the fluid shift. Okay? And the blood flow rate here, as you can see, it's from 400 to 800 ml per minute. That's really fast. And the higher you go, the lower the blood pressure can drop. Okay? And there are different access sites that we can use. We have AV fistula, we have AV graft, and we can also use dialysis catheters to this patient. And as I said, the treatment varies. If your patient is a new patient, the treatment can start from 1.5 hours. But if your patient has been doing hemodialysis for a while, then their treatment can go up to 4 hours. Okay? And another thing in here is complications. So your patient can develop anemia with hemodialysis, can develop infection, especially if they're using dialysis catheters, and pseudoaneurysm to their AV fistula or AV graft. It can happen to them, okay? Now, if they are on peritoneal dialysis, this can be done at home by your patient. So your patient is knowledgeable about their peritoneal dialysis. They know what to do. They know how it's set up, okay? The access site here would be peritoneal dialysis catheter, okay? You will see it um, in their abdominal area, okay, close to the belly button. So you will see it there. And again, it's a catheter, so we want to make sure that we perform aseptic technique. And as I said, frequency of treatment for PD, it is every day. And the length or the duration of the treatment, it varies. Some patients do it at night, okay? While the last one, but not the least, is CRRT, which is a blood filtering procedure also, like hemodialysis, but this is only done to patients in ICU. So patients who have very, very low blood pressure, we do CRRT. Okay? Now we already discussed this, so I'm gonna move on. So this is the dialyzer. Okay, it has this fine fiber inside. And this is how dialyzer works. So what happens, this is the blood from the patient, then it goes to the dialyzer and it's filtered and all the toxins were removed. So it goes in here through diffusion and then the blood now is clean and then it goes back to the patient. So that's how it works. Okay. This is the dialysate bag and you might see this that we use this in CRRT. And I'm gonna show you some of the hemodialysis access sites, okay, so that you're familiar with it. So we have AV fistula and AV graft. So let's start with AV fistula. So AV fistula, remember you listen for bruit and you palpate for the thrill. This is what it is. And it's AV fistula, it means that we're using their own artery to be anastomose in their vein, okay? While with AV graft is we use a graft or a synthetic, like a tube, to connect the artery and the vein. And this is commonly done to patients who have very, very poor perfusion and circulation in their arm. Like for example, if they have PAD, PVD, then they can have the AV graft. Now, this is what the fistula looks like. So, if we stick the patient too many times, it looks like they have scarring in here. And this is how big the needle that we use. This is 15 gauge. So we commonly use 15 or 16 gauge, after we assess the fistula or the graft. So it depends. And the patient knows most of the time what gauge we usually use to them. Okay. Now, if the patient has been on dialysis for a long time, and again, earlier I told you that with hemodialysis and even with the other types of dialysis, they can have infection, okay? Infection in the fistula, infection in the graft. If they develop that, we cannot use the access sites because your patient will be at risk to develop sepsis, okay? Another complication that you might see is, it looks like this, like the fistula are, huge, okay? That is due to the repetitive trauma, and this is pseudoaneurysm, okay? Now, nursing considerations. I mentioned to you about checking for the bruit by auscultation and for the trill. Remember, if there is no trill or bruit, we cannot access the site, we cannot use it. And there are times your patient will have a temporary dialysis catheter. Another thing, if your patient has fistula or graft, remember to avoid doing any blood draw or any measurement of blood pressure. That's a no-no because it can mess up the access site, okay? And normally, if the patient's fistula and graft, if they are new, then we have to wait for about 21 days until it is strong enough, to be connected to a dialysis machine, okay? So sometimes patients who have new fistula or graft, they will need a dialysis catheter temporarily, while we wait, okay? Another thing we emphasize to our patient, no lifting, no using of the arm or leg where the access site is. And we have to monitor for any signs of infection. So we teach our patient when they go home to monitor their temperature, okay, to monitor their access site and see if there are any localized infection that can become systemic later on. Now, this is the tunnel dialysis catheter looks like. So it has red and blue because red represents artery and blue is the vein, okay? So again, artery is away from the heart, V as in vein is going back to the heart, okay? So you might see here the 2.1 cc in here, or 2.1 ml. That's the amount of alteplase that we put in if there's a possible clot or if the catheter is clogged, okay? So we use that numeric value there to put, okay? And then of course we extract it after putting it for about 2 hours after putting it, and then flush it with normal saline, okay? Because we need to keep it open. And look at this image. Does it look clean to you? Or how's the dressing, right? And how's the connection when it comes to dialysis? It doesn't seem correct, right? And this tells you as a nurse that, dialysis is one of my specialties. So I know what this means. This means that this catheter might be having problem, okay? There might be a clog, or there might be high pressures that the dialysis machine is telling me that we need to report to the healthcare provider. Remember that we need to dress this properly. This is not good when you see a dressing like this, okay? Now, considerations, I mentioned to you already the alteplase, okay, to remove that clot. And again, monitor for any signs of infection. Since we're using a catheter, your patient is at risk to have CLUB-C or central line associated bloodstream infection. So make sure you monitor the site for any redness, warm discharge, any elevation of WBC and fever. Because if they have that, we have to draw blood for blood culture and send it to the lab. Okay? Now, dialysis catheter is another. So you might see this. The only difference of this to the tunnel is that it has a third port. And here, as a primary care nurse, you can use that to give fluids, to give medications. But for the red and blue, that's where the dialysis ports go in. Okay? Nursing considerations, pretty much the same with what I've mentioned. earlier about the tunnel dialysis catheter. Now, with hemodialysis machine, it looks like this. It has a dialyzer. It has these 2 gallons with a bicarb and with electrolytes. Okay, it's just to show you. You don't have to memorize all of them, but at least understand what a dialyzer is. Okay, and this is what it looks like in reality when you work as a nurse. It's a lot of blood, guys. So if your stomach is not as strong, okay, or if you get nervous looking at it, because it's really a lot of blood, and those blood is coming, this blood is coming from the patient. Okay, here is the electrolytes, here's the bicarb, here's the machine. Okay, looks like this at very close. And here again is just to show you how the dialyzer work, and I already explained it to you earlier. Okay, another image of a dialyzer in a very close manner. Okay, it's just to show you. And again, before anything that can happen, you want to make sure that you check the bond and creatinine of the patient. You want to check their electrolytes, their baseline CBC and AVG before dialysis. Okay. And again, CBC is checked because if the hemoglobin and hematocrit are critically low, then blood transfusion is needed. And blood transfusion can be done during dialysis. Okay, check the vital signs of your patient. If the blood pressure is critically low, then they can have CRRT instead rather than hemodialysis. So make sure do your due diligence of assessing your patient. Complications of hemodialysis, again, since the blood flow rate is really, really high, it can go up to 800, they can develop hypotension. So in here, you give IV fluids. If they are complaining of muscle cramps, again, you give IV fluids. If they lose a lot of blood, then they need blood transfusion. Okay, they can also develop hepatitis due to their low immune system and hepatorenal syndrome. Okay, so remember this slide because this is commonly asked in NCLEX. Now, peritoneal dialysis. Again, with peritoneal, this can be done at home, and there are 2 types. It could be automated. This can be done while they're sleeping. So some patients, they choose this one because especially if they work in the morning, they cannot do peritoneal dialysis, then they want to do their dialysis at night while they're sleeping. Or if they want to do a continuous peritoneal dialysis, this can be done up to 4 times daily. Okay, so I know I write so many things in here just to show you how this peritoneal dialysis works. Okay, so first is what's gonna happen. This is the solution bag. So the first thing that happens is whatever is in the solution bag will go into the machine and going to the peritoneal cavity of the patient. And the term that we use for that is fill. Okay, after it fills, then it will dwell on it. Dwell means it will stay in the peritoneal cavity for a certain period of time. We're talking about 4 hours, 7 hours, depending on the nephrologist order. And that's where the exchanges happens and where the toxins are separated. Okay? Once it's done, it goes back out to the machine and then it goes straight to the drainage bag. So the third one would be to drain. Okay? So that's the process on how this peritoneal dialysis works. Now, this is what it looks like. And this is what I explained to you earlier, but remember, fill first, then dwell, and then drain. This is another image to show you what happens inside, okay, from dialysis fluid supply. And this is what the PD catheter looks like. So again, it should have a nice dressing in there. You can also put a gauze here, like a 4x4. So we protect it so that your patient will not have infection. And this is the peritoneal dialysis machine looks like, okay, with a lot of tubes and different nursing considerations here, okay. So again, when you have a patient that had peritoneal dialysis, once they're admitted, reinforce the prevention of infection, tell them they need to have high protein diet and monitor their vital signs. Now, when it comes to peritoneal dialysis, there's a lot of complications. And in here, you have to monitor for any exit site infection. You want to monitor their peritonitis. You want to monitor, hernias. And hernia can happen because of increased intra-abdominal pressure. And because earlier I mentioned to you that some of the component of the dialysate should stay there or should dwell for a long time. So that increase intra-abdominal pressure. Your patient can also have lower back problems because of the increased intra-abdominal pressure there. And your patient is at risk to bleed, okay? And they can also have pulmonary complications because of the dwelling time of the dialysate. So the dwelling time can really affect their lung function also, because it can displace the diaphragm, okay? And they can lose a lot of protein because when you check the drainage bag, that includes also a protein component. That's why we recommend for our patients to have a high protein diet. Now, CRRT. Earlier, I told you that CRRT is only indicated to patients who are in ICU. And this is an example of a CRRT machine that you might see in ICU. And as you can see, there are different bags. We have dialysate solutions here. We have normal saline in here, or it could be a dextrose solution. And then we have a drainage bag here. This is another image that you might see in ICU. Okay, so here we have the CRRT machine. Our patient has oxygen ongoing in here. This is another image to show you the different parts of CRRT. I am not asking you to memorize it, but again, learning is, that makes sure that you're aware of what these different parts mean, okay? But I'm not asking you to memorize it. You will not be tested on it in your NCLEX, so just understand CRRT is for ICU patients. Now, considerations. When your patient is on CRRT, this is done 24/7. So, ICU nurses are responsible to change the bags and monitoring the site. Remember, we only use dialysis catheters for CRRT, okay? Because it's 24/7. The fistula and graft, it's not safe to use them, okay? Because again, if you're using a 15 gauge and it might be dislodged and your patient might be bleeding, and before you know it, your patient's bled a lot already. Also be careful. So we only use their dialysis catheters. This is only used for patients who have low blood pressure and those who are critically ill patients. Okay, let me know if you have any questions about this, and I hope you learned a lot about these concepts. Thank you. Here are my references.